Okay, sir. We can minimize this. Right. Hi, so good evening, everybody. This is Akash from the FCPI end. So welcoming you all to Critical Care Medicine Module Part 2. This is our first presentation from this module, and this is going to be an interesting one. This is something which is not very regularly taught to the clinical pharmacist. So today we have Dr. Chaitanya with us. Sir has done his general medicine from KMCH Coimbatore. Then he has done his Indian Diploma in Critical Care Medicine from KMCH Coimbatore. Then he has worked as a neurology registrar in KMCH Coimbatore. And then he joined as a consultant critical care in Royal Care Institute of Critical Care Medicine. And now he is the senior consultant and HOD of critical care for KIMS Gachibowli, Hyderabad. So special area of interest is neurocritical care, neurological emergencies, digitization in ICU. Sir is one of the reasons because of which my ICU has today a digital pathway called as ICA. So we are completely computerized ICU in South India. So sir is going to talk about today imaging, which consists of chest X-ray and the CT brain. So over to you, sir.
Thanks, Akash. Thanks for that nice introduction. It is always nice to meet clinical pharmacists who especially would like to definitely pour in their information for improvement in care in ICUs. And the the help which they can do is more valuable when they get to understand what a physician is going through his mind when they're attending to a patient. So imaging forms a major decision tool while in the ICU for a patient, where we take decisions on antibiotics, we take decisions on fluids, we take decisions on diuretics, anti-edema measures in neuro patients. So today's topic of chest X-ray and CT, I suppose some basic understanding would help you also to start applying what you're seeing today in your day-to-day practice when you go for rounds and when you try to see where you can optimize medical management. So chest X-ray, as you all know, the X-ray beam which passes through our body would lay some uh, opacities or translucencies based on the material which these X-ray beams traverse. So we all know how an X-ray is taken. We have a X-ray machine which throws up X-ray beams over to us, and we have a film which captures these beams. Now, in between the medium, whatever through which these rays are passing, will impart some changes which we capture as an image and which we see on a film to interpret the various conditions. So air is always which always appears black because most of the X-ray beams get to pass through. But when we come across bone or a metal, majority of the X-ray beams are reflected back. So we get to see a white shadow on the film when this passes through. So in between this is the fat and the soft tissue. So we see air as the most black and metal or bone as the most white. So with this basic principle, we try to use this in various interpretation of our X-rays or CT scans, and then to decipher our clinical findings or support our clinical diagnosis. There are many mnemonics where you find how to interpret an X-ray, what we are seeing. The first would be P patient. P is patient is for to identify that you are seeing the image of the particular patient whom you are concerned with. Next, you see whether we are seeing an optimal film. Optimal film in the sense, for a chest X-ray, have we taken an image in a proper inspiratory phase? Have the X-ray beams adequately penetrated? Are they under penetrating or over penetrated? Is the patient properly exposed? Is the chest X-ray line in midline or it is a rotated film? We look for all tubes, be it ET tubes, drain tubes, uh, Riles tubes, feeding tubes, all these things. So all these things are what we routinely see in an X-ray. So as I said, the moment you see a X-ray, first thing you need to observe is for patient data, patient metadata. So what is the name of this patient? When is the X-ray taken? And their registration number, just to be double sure that we don't miss just by the sake of the names. Next comes, this is a mnemonic again called RIP. That is, R stands for rotation, I for inspiratory film, and P for penetration, adequacy of penetration. So if you can see here, how do you determine rotation is by looking at the medial ends of the clavicles. When you see both the clavicular ends are close or in the midline or very or equidistant to the central spinous process. As you can see, I don't know if you're able to see my mouse process. Uh, yeah, if you can see now, you can see now, these are the spinous processes. So when you see both the medial ends of clavicles being equidistant to the mid-central spinous process, that means we have a properly aligned, non-rotated film. You can see on the image on the right side where the clavicle on the right is far away from the medial clavicular head of the left clavicle. So this means this is a grossly rotated film. So these are the conditions where you always get misinterpreting that about mediastinal shifts and all. So first thing is, as I said, we need to be sure about the rotation of the film. Next comes whether we have taken an image of an inspiratory film or not. So how do you ascertain that? So at full inspiration, diaphragm should be observed at about level 8 to 10th rib posteriorly or the 5th to 6th rib anteriorly. You can see the difference between the right and the left images which I have shared. A proper inspiratory film will have at least 8 to 10 ribs which will be appearing for us on the posterior aspect, or the anterior ends maybe at least 5 to 6 ribs should cross the baseline. If I the same X-ray, if I would give you the count of those ribs, you would understand. So a properly inspired film, on the right side, you are having the count of the anterior ends of the ribs. So this is 1, this is 2, 3, 4, 5, and 6. On the left side, the count is regarding the posterior part of the ribs, where it joins the spinous process. So for a properly inspired film, you will see at least posterior aspects of 10 ribs or anterior aspects of at least 5 to 6 ribs crossing the mid-clavicular line near to the diaphragm, I mean above the diaphragm. So next comes P. P stands for penetration. A properly penetrated film would ideally give you the lower thoracic vertebra, which should be visible through the heart. If you are unable to see that, that is an underpenetration, as you can see on the right side. Or if your bronchiovascular structures behind the heart, they also should be seen. If you are unable to see any bronchiovascular margins and whole of lungs look pitch black, then this is an over-penetrated film. So we need to find the right spot where between the cardiac shadow, you should be able to differentiate the lower thoracic vertebra. And you should be able to appreciate the bronchovascular markings. If you're erring on either side, we'll get either an underpenetrated or an overpenetrated film. So 4 major questions how we do an X-ray. We look at posterior PA view, a lateral view, an anteroposterior view, or a lateral decubitus view. PA view is the common X-rays which I have been depicting all through, but these routinely are done not in the ICU, but in your radiology departments. In ICU, for a patient who is lying on their bed, most of the times, we always try to get a anteroposterior view. As I said, these are the examples. The first one is a PA view. The second, the pointer which I'm pointing, is the AP view. The third one is the lateral view, and the fourth is the lateral decubitus view. So why do we need a chest X-ray in the ICU? Most often, we get an X-ray to see our clinical diagnosis if there is any lung pathology happening, or if the patient has undergone any clinical deterioration in terms of his respiratory function. If we have done some procedures like we have just intubated him, or we have just placed a central line, or we have placed a Riles tube to look for its position of these tubes, or to assess the volume status, sometimes like is the patient having pleural effusion, pulmonary edema, does the patient have a pneumothorax? All these are the main common reasons why X-rays are frequently done in ICUs, because ICU, high acuity care, all these become part of the care. So we all need to be aware of what's happening in the chest. This diagram here depicts a rough understanding for us to understand the anatomy, what structures are seen. Basically, we see lungs on either side, which are usually black to gray. And in the middle of both the lungs, we have a shadow, which is white in color, which comprises of heart and the mediastinum. So the lower end forms the cardiac shadow, and just above it towards the sternal or the mid-clavicular end, we have the mediastinum. We have two borders, one on to the right and to the left. The borders are usually formed by, on the right side from above, if you see, we have a superior vena cava as a border, and down as it goes, we have the right atrium as a border until the diaphragm. Majority of the cardiac shadow is contributed by the right ventricle, and the left margin of the cardiac shadow is usually the left ventricle or the apex of the left ventricle. From above, if you look at the left margin, we have a aortic arch which forms a small knuckle to start with, and below that you have the pulmonary trunk or a left atrial appendage, which becomes prominent when it is abnormally enlarged in size. So typical findings or routine common causes where we look for are pneumonia. So why should a pharmacist know about pneumonia? So here this comes where you also take a call, like if you have a patient who comes with a diagnosis of pneumonia, you have an X-ray or a CT. But for those patients ongoing care in the ICU, when antibiotics are being escalated or changed, you should also know where the criteria for VAP all comes. A VAP, by definition, has a new fever with a new change in their oxygen requirements or new change in their sputum characteristics, along with associated with radiological changes. So always try to identify which features would support a pneumonia. So a pneumonia is nothing but infections of the lung parenchyma. So what happens? A lung parenchyma, which ideally has to be filled with air, now gets solidified, where the air quantity comes down and it is filled up with fluid. So that leads to an airspace opacity. Based on the airspace opacity, its location, where it is, upper zone, middle zone, lower zone, only one side, right or left, based on the pattern of involvement, whether it is patchy, diffuse, we come to a clinical diagnosis. Here you can see a staunch difference between right and left. So what I'm trying to show is, here we have an opacification in the left middle zone. But within the middle zone, if you can see fine black lines. These are the airways which we are seeing. So these airways, which are otherwise not visible, now are visible because the surrounding lung parenchyma, which has to be black, has turned white. So this is called as an air bronchogram. When your airways, which are filled with air, which are black, which are surrounded by substance or the lung parenchyma, which is not having air, this forms a clear outline for the airways to be visible to us. That is called as an air bronchogram, which is a very characteristic feature of pneumonia. So there is another sign we could discuss here that is called a silhouette sign. So silhouette means having a staunch difference between two parts of a lung or a chest, which have different penetrancy or different properties. So as we all know, lung, which is filled up with air, is looks black. Heart without air looks white. So this border is usually very clear. But when you have any disease process going on, which is obliterating this difference or difference of obliterating this margin, that's when you think that there is some pathology arising there. For example, the number one, which is shown here, is the left heart border, left cardiac border. So when you have obliteration or this loss of the silhouette sign, where the margin between the heart and the left side lung is lost, then we need to think of a pathology arising in the lung or the lingular lobe of the left lung. The same way, if it is happening on the right, close to the diaphragm, here we are losing the differentiation between the diaphragm and to the lung parenchyma. We need to think of a right lower zone pathological process. When you look at the C that is very close to the clavicular head. This can be arising out of a pathology close to, it could be arising out of the bone, it could be arising within the lung parenchyma, or it could be problem of the aortic arch as well. The four you can see here, which is happening in the well in the periphery. Periphery is usually a pleura. So pleura, bone, and the lung. This is where a pathology we need to suspect of. So always we need to look at the margins of different structures where we are seeing, and we need to see if we are missing on the borders, a loss of differentiation between different structures. So pleural effusion, as I said, pleural effusion, the first place where we look for pleural effusion are the costophrenic angles. That is the angle formed where between the ribs and the diaphragm. That is these corners. So these corners are usually very acute. But when you see blunting of those corners, that is the early signs of pleural effusion. But approximately you require roughly around 200 ml of fluid to start detecting that in a PF film. But if you want to find that even at a lesser volume, there is a special mode of X-ray called lateral decubitus X-ray. When you try to position the patient laterally in a sleeping position, you have this fluid forming a layer, so that can pick you up an early stage of pleural effusion. When you have pleural effusion, what happens is, as I told, the lung, which otherwise has to be filled up with air, is filled up now with fluid, which will exert an opacity in our X-ray. And very clearly you see like how all fluids in a capillary tube form a meniscus. So within the chest as well, within the pleural space, this pleural fluid forms a meniscus. So presence of a meniscus sign will definitely tell you that you have a pleural effusion. You have an opacity with a meniscus sign, that is, it is mostly pleural effusion. Apart from pleural effusion, it could be any problem with the parenchyma as well. So to differentiate that, meniscus sign helps us. Here you can see many of your, if you're posted in a cardiac ICU, often you see patients who come with shortness of breath, who are hypoxic or tachypneic, and X-ray showing diffuse opacification exerting presence on both the sides, and you need to try to describe this opacification. You see, it is diffuse on both the sides. It's bilateral. You have it predominantly in the center or towards the hilum, and it is little less towards the periphery. So this pattern, when you observe, it tells it could be, there could be chance that it could be a pulmonary edema. So pulmonary edema produces two types of fluid accumulation. In early stages, it starts with interstitial fluid accumulation. And in a little more advanced stage, we have alveolar flooding, and it causes alveolar opacities as well. That's what we see. In the first line, first X-ray, you see faint opaque lines traversing all over the film. But right side, in the second film, what you see is dense opacities in the both the parenchyma. So it could be either interstitial pattern or dense alveolar opacities. So next comes how we identify COPD X-ray. So why is it important to observe pulmonary edema, COPD and all? So only if we come to conclusion why such patient is breathless, whether it is out of wheeze or it is a pulmonary edema, you can optimize on your drugs. Many a times we see Patients who are breathless and hypoxic get a cocktail of drugs, including steroids, Lasix, antibiotics. We don't know which has worked. So all these tools help us in identifying what is the cause and narrow down on the specific modality of care. These patients like COPD, if you are able to identify on an X-ray, how do you identify is by, so COPD is a chronic obstructive pulmonary airway disease. So they have difficulty in the air getting exhaled out. So over years and years, when air builds up inside, there is something called as air trapping, or there is something called hyperinflation. So a hyperinflated chest, how does it look? There will be flattening of diaphragms. There will be a barrel-shaped chest, and we see almost all possible ribs across the lung window itself. So this indicates COPD. For a clinical pharmacist point of view, you need to, by looking at this X-ray, you need to consider how the modality of therapy, what you're choosing, how we are giving bronchodilators. Is there a scope that patient can breathe that adequate drug reaches the patient at all? You should be cautious about giving sedatives because they are very prone for carbon dioxide retention. Oxygen therapy, even giving more oxygen can land them into type 2 failure. So from a clinical pharmacist point of view, you need to also look at these things, especially because your drug choices and drug delivery modalities also you can guide the ICU team. Here you can see in this X-ray, if you can see, there is a gross difference between the right lung and the left lung. So the right lung, you're able to see clear bronchovascular markings, but in the left is fully black. So what does this tell? That means there is excess of air within the left, usually happens with pneumothorax. We always read, so a pneumothorax is an emergency. And when this pneumothorax, you always see the cardiac shadow to the left. So what's happening here? Even your heart shadow is moving towards right. That means the air inside the chest is strong enough or is under high pressure that it is pushing the heart to the opposite side. So that is an emergency situation. So we need to identify any such condition called causing tension within the thorax. Called this is with because arising out of air, we call this a tension pneumothorax. But we need to also identify subtle pneumothoraxes because these are the ones which, when picked up early, we prevent such a situation or in such an emergency situation. Here you can see otherwise normal looking lung, but when you look at the corners, epices, that's where you find early stages of a pneumothorax. You can see here, this is a patient who presented to us with trauma. You can see here a rib is fractured, but underlying the rib is what we are seeing a hyperlucency, or seeing a little blacker chest, blacker lung space compared to the lower zone. So this means there is a pneumothorax which has every high chance that it can progress. So these are the ones we need to pick up. So when you see an X-ray, don't miss on looking at the apex and the bones. So we can catch on early changes which we can always handle. This X-ray, which is looking at something called as cardiothoracic ratio, is usually looked at in PA view, but not in an AP view, which is routinely done in ICU. So what we learn from a PA view X-ray, we can't blindly apply on an AP view X-ray. So in a PA view, they look at the cardiothoracic ratio to look if the cardiac shadow is enlarged, basically. If the cardiac shadow is enlarged, then we can look at causes why it is happening, especially like signs of if there is cardiac failure or if there is excessive fluid around the heart, like pericardial effusion, or in kids, especially if there are congenital anomalies where you identify based on X-ray, we can look at an echocardiography to see if there are any valvular or congenital cardiac anomalies happening. This is one of the most common indication why an X-ray is done in an ICU, that is to check how the tubes are placed. An ideally placed tube usually lies around 4 to 5 centimeters above the carina. Carina is the trachea. Trachea it divides into right and left bronchus, and that juncture is called as a carina. So if a tube is placed too high, there is high chances that the tube position can be dislodged or the tube can come out with the patient movements or the patient care being given. when it is too low or too advanced, crossing the carina or hitting the carina, there is always chance that the tube can get blocked with carina. It can induce vasospasm, or the air entry might not be equal to both the lungs, and which can lead us into problems. For example, in this X-ray, if you can see the tube, you can see, I feel you can be able to appreciate the tube. You can see the tube curving on to the right. That means the tube, as we are unable to see the carina here, but the tube is crossing the midline and going into the right chest. That means the air is selectively being delivered only to the right lung. But the left lung, because there is no air entry, has become collapsed, and it is called, it is caused a collapse of the left lung. So this is an iatrogenic problem. When you pull out the tube, then the air entry comes up back to the left lung as well. The lung gets opened and oxygenated. So second is the feeding tubes. So the ideal place how we place tubes, if we are using a nasogastric tube, we need to secure the tube at around 60 centimeters nose level. Or if you are using a orogastric tube, we require to fix it at 50 centimeter level. This assures that the tip of the tube is at least 10 centimeters beyond the esophagogastric junction. The feeding tubes are mostly placed blindly through the nose or through the mouth. So we need to make sure that it has entered the right path, that is your esophagus. So confirmation by clinical judgment, by a gush of air when you inject through a syringe and here through an auscultation, that is the first best judgment. But sometimes in a grossly distended abdomen, you may not be able to clinically listen. An X-ray comes in help at that times. If you see that the Ryle tube not crossing the carina, or it's not in the midline below crossing the diaphragm, and it's taking turns into any of the thoraces, then it is ideal that you pull out the tube and replace it and confirm the position. Here in this X-ray, you can see the Ryle tube, the feeding tube, is following the airway. So it has not crossed the carina, first point. Second, it has turned right, and you can see a lot of opacification within the right lung. That means the feeding tube has been malpositioned into the right lung, and there is content, or the feeding content, which is gone into the right lung, leading to aspiration pneumonia or right lung pneumonia. Central lines, that's the other reason why we do chest X-ray. Here, I try to identify where the tip is located. Ideal location where the central line tips should be are the cavo-atrial junction. So a tube which is lying more advanced, where the chance that it can go into the atrium, it can injure the walls, or it can lead to endocarditis. More higher the tube, then there is high chance that, because these are venous lines, there's high chance that they can get blocked or they can get thrombosed. So finding an ideal location, or suppose if there are dialysis lines, we may not be able to get adequate blood flows to do a dialysis. So apart from position of the tube, we can also see about any hydrogenic problems arising out of the invasive procedure that we have done to place these tubes, like causing hemothorax, pneumothorax, etc. So I think the routine common findings in an X-ray, like identifying an pneumonia, identifying pleural effusions, identifying pneumothorax, identifying if the patient has COPD. I think I roughly shown you adequate images. One thing we should not forget is, whenever we look at an X-ray, at the end, after though you eyeball it and come to a conclusion, we should never mistake or forget to look at these epices, bones to look for fractures, cardiac shadow or the borders to look for any evolving, progressing pneumonia, to look for diaphragm, and also under the diaphragm. You get a routine chest X-ray, but you find free air under the diaphragm. That means there is some abdominal pathology going on. Okay. So with this, I'm done with X-ray. Now let's move on to CT brain, our next topic. CT brain or computed tomography is something which uses the same technology of an X-ray, but uses multiple beams of X-rays which are being captured with a multiple array of reflectors which are placed around the patient. These enhance the image acquisition in terms of orientation, clarity we get based on the number of collimators we have to generate X-ray beams and capture it. So here today we are discussing CT brain image. As I said, first thing we need to look at the patient's metadata, that is patient name, patient age, and patient ID. Once we confirm that, then we can go into looking at the image per se. So basic anatomy, cranium or skull is formed out of many bones, be it frontal bone, parietal bone, temporal bone. So unlike other bodies in bones which form joints, here a joint between two cranial bones, we call them as sutures. So inside this skull, we have the brain parenchyma. So brain parenchyma usually floats in a CSF space, and parenchyma per se, inside it also has a fluid space called as ventricles. And these places are divided by some meningeal, they are covered by, the brain parenchyma is covered by meningeal coverings called dura mater, pia mater, and subarachnoid space. So based on, these are the structures which we look into to identify various pathologies happening in the brain. As I said, you can see a diagram, simple diagram depicting the base of skull, which where the various bones forming the skull, the frontal bone, the parietal bones, the squamous temporal bone, and the occipital bones form various fossa in the brain called anterior cranial fossa, middle and posterior cranial fossa, which harbor other structures like the frontal bone, the frontal lobe of the brain, the cerebrum of the brain, the posterior brain structures like occipital lobe and the brainstem. These parts of the brain are separated by the reflections of the meninges or the dura, which form uh, partitions, which let right side parts of the body to stay right, which let the anterior and posterior have occupied their own places. So these reflections are examples like falx cerebri, which forms a partition between the right and left, a tentorium cerebelli, which forms a separation between the anterior brain structures and the posterior brain structures. This image would show you a depiction of various sinusoidal cavities lying within our skull. We have ethmoidal air cells, ethmoidal air cells. Posterior to it, we have the sphenoid cells. We have the mastoid air cells, and maybe maxillary sinus is not depicted in this image. Why is it important is because most of you in ICU practice would have seen patients, neurological patients who have been in the ICU for more than a week or more than 10 days, developing fever where we are unable to localize source. When we look at the sinuses, if there is severe mucosal thickening or if there is flooding of the sinuses, we should always think that sinus infection could have been a cause of a fever. So here, what all pathologies we look is, again, we will go through these things. So first, skull, as I said, is formed by cranial bones. So we look at bone fractures. So like any other bone, these cranial bones also have something called as an outer table and an inner table. And in between is the marrow or the diplo, we call. So when there is breach in these two layers, outer table and inner table, it causes a fracture. And in these windows, you can see, so in these images, you can see a fractured bone with a tip protruding inside onto the brain. So this is called a depressed skull fracture. Same way, when you look at this base of skull fracture, here you can look at the right temporal bone where you can see a fracture extending across, causing a break in the squamous part of the temporal bone. As I said, brain, the skull, inside the skull, the brain is floating in some cerebrospinal fluid, and it also has spaces within the brain parenchyma that form the ventricles. This is how the CSF circulates. So the CSF spaces within the brain, that is, they are called as the ventricular system. So ventricular system is formed by two lateral ventricles, which open into a third ventricle through foramen of Monro, and the third ventricle continues down to through the brainstem, and then proceeds into the cisternal spaces through the fourth ventricle, and then it goes into the spinal canal. So why do we need to know all this? Is because we gauge the intensity of the parenchymal diseases or its influence on the pressures within the brain, the intracranial pressure, by seeing which three structures within the brain are getting compromised. Three structures within the skull are the brain parenchyma, the blood flow, and the ventricular CSF space. So there is a Monroe principle where when the intracranial pressure rises, either of this component gets compromised to compensate for the rising space. Suppose say there is swelling in the brain, then first thing that happens is the ventricular space narrows down, the CSF is let out, and the CSF ventricular space narrows down. If there is ventricular space getting dilated, like in situations like hydrocephalus, which I'm going to show, the sulcal spaces all around the brain get compromised, get obliterated. So based on this, we get to identify, to look for signs if there is signs of raised intracranial pressure. So example, here we have the image on the right is showing very dilated ventricular system. So in this ventricular system, we have something black in the center that is filled up with CSF. As we know, fluid looks very dark on a CT image. Bone looks very white. This is called as hyperdense, and what looks dark or black is called hypodense. So when you have ventricular system dilatation, this is called as hydrocephalus. In the other image where you can see the peripheral sulcal spaces or the gyral space or the CSF spaces over the surface of the brain, you are unable to differentiate any of them. That means there is a lot of edema here. That's one reason why you can see even the ventricle size has become quashed. So when the brain parenchyma swells, what happens is the CSF space tries to obliterate to compensate for the rise in pressure by letting the ventricles get shrunken, and the CSF space also obliterates. So this helps in identifying how much of anti-edema to give, or if the patient is already on some anti-edema measures like mannitol or 3% saline, how do you choose, how do you monitor whether you have achieved the maximum osmolality or the maximum treatment threshold, what we say. Suppose you are using mannitol, how do you know? Then you need to look at the osmolar gap. If you are using 3% saline or hypertonic saline, then you look at your serum osmolality, whether you have achieved something around 320 or not. That's how you titrate your anti-edema measures. For a clinical pharmacist perspective of view, identifying intracranial pressure would help you in continuing your anti-edema measures, whether you have attained your target or is there a scope for further hike up in drugs, or whether you need to monitor further. So this image depicts you the gray matter and white matter. So gray matter in the brain is usually towards the periphery. Gray matter is formed by your cortical neurons. So cortical neurons are the neuronal cells form gray matter. From here, all the axons which carry the information or which carry the impulses from the neuronal cell traverse all across the brain to enter the spinal cord. So this axons form your white matter. So apart from this gray matter, where the cortical neurons are, the other areas where we have the gray matter is the basal ganglia or the caudate nucleus, lentiform nucleus, thalamus. All these structures also form the gray matter. The rest, the areas which are between, which look less or little more darker than your gray matter, form the white matter. So in this diagram, I think you would be able to understand these are the deep ganglionic structures or the basal ganglion, what we call. So basal ganglion is formed by caudate nucleus and the lentiform nucleus. And down we have a thalamus. These are all deep brain structures which form the gray matter. So the area between, as you can see, if you can follow my mouse tracker, the area which traverses between the caudate and lentiform anteriorly and like lentiform and the thalamus posteriorly is called the internal capsule. So this has bundles of all the motor fibers, which while crossing over to the opposite side form a capsule-like thing or a barrier-like thing called as an internal capsule. Lateral to the lentiform nucleus, we have a small white matter pathway called as an external capsule. Gray matter lateral or outer to the external capsule, which is just under the sylvian fissure, we call as insular cortex. So we have from the periphery, if you look, we have a skull, then you have CSO space, then you have the cortical gyri, which close to the sylvian fissure we have insular cortex. After the insular cortex, we have the external capsule, then your basal ganglion. In between, you have the internal capsule crossing over. Deep to that is your ventricular system. Same way from the opposite side. So any pathology affecting these structures, like as we said in pneumonia, where the differentiation between these things gets lost. So that means there is some pathology happening here, which I'll discuss in the coming images. So the right side again, as I say, is a coronal view where we see various other structures. So here we are looking at something which is shaded blue in called MB stands for midbrain, pons, and medulla oblongata. I was telling you of structures which separate right to left and anterior to posterior. You can see a fine line crossing in between, a fine white line. This is the falx cerebri that separates the right and the left brain. In this diagram, you see a green dotted line on your on the second image. That is the tentorium cerebri. This is a folding of the meninges which separates the anterior brain structures to the posterior brain, posterior cranial structures. The posterior cranial structures, namely your cerebellum, midbrain, pons, and medulla oblongata. These three form your brainstem. So here, the common pathologies which we look at in the images are like, so this is a CT brain depiction of a acute infarct. So what happens, as I said, when your brain gets infarcted, there is swelling in the brain and the brain parenchyma gets filled up with fluid, causing edema. So when you have neuronal cells getting damaged, like because lack of blood supply, they produce edema or cellular edema or cytotoxic edema. That becomes to appear black in color. So that's why we see a hypodense area. And from compared to opposite side, what you can also see, you can see in between there are black spaces, that is the CSO spaces or the sulcal spaces. Here in the infarcted area, we are unable to see them. That means this edema is obliterating the CSO spaces as present around that gray matter, and the parenchyma itself is looking hypodense. That means this is the lesion of pathology which we are focusing on. An additional feature which you need to look when you identify such things are try to look at the vessels. In CT brain, in a plain CT brain, it is difficult to always identify blood vessels. We need to do a contrast scan to look at the blood vessels. But in an acute infarct, many of the times, what we see is a thrombus or a bright area following the vessel's path, which means that there is something occluding the blood vessel. That is called a dense MCA sign. This image shows you a dense middle cerebral artery sign. That is, there is chance that there is a vessel that is occluded. It gains prominence in today's day because in acute stroke, as all of you know, intravenous thrombolysis is the standard of care. But over the last 5 to 6 years now, there is huge stress upon trying to do thrombectomy. So identifying such vessel occlusions also forms importance. Apart from thrombolysis, we should always look a patient, whoever is fit for thrombolysis. Also look if there is a need for thrombectomy that needs to be done, that will significantly improve your outcomes. These images show you something that is unusual or that is hemorrhage. So as we said, the brain, the cranium, which is the bone, which is very hyperdense or white in color. And the brain parenchyma as such is gray or black. So any other structure which is white in color, which crops up as a pathology, is most commonly blood. So based on location of blood and based on the shape of the opacification, we try to identify what sort of bleeding it is. The first image you can see a lens-shaped bleed. That means it is usually an extradural hemorrhage. Usually it arises out of an arterial bleed between the skull bone and the dura mater. So it is always under tension. So that's why it forms a lens-shaped bleed. The second one, we are seeing hyperdense opacification in the fluid space or the CSF spaces. So what are these structures called now? Usually we see these spaces which are dark white lines in this image as black, because these are your basal cisterns, which is usually filled up with cerebrospinal fluid. This is our Sylvian fissure, which is again a CSF space. Now you are seeing here blood here, which is filling up these CSF spaces. That means there is bleeding into subarachnoid space or into the CSF space that we call as subarachnoid hemorrhage. The third image is showing you a crescent-shaped bleed. That is blood accumulating in a form of crescent shape between your brain and the skull. So this blood usually lies beneath the dura mater. So that's why it is called as a subdural hemorrhage. If the bleed is located out of dura, between the bone and the dura, we get an extradural hemorrhage. Most common cause will be a arterial bleed. A bleeding which is happening beneath the dura usually forms a crescent-shaped bleed, and we form it as a subdural hemorrhage. What is the importance that we identify here? Extradural hematomas can progress rapidly, and the many drugs like mannitol or 3% saline hyperosmolar therapies which we give will have a potency that they can increase your bleeds. The emergency management would be a surgery in extradural hematoma. But for subdural hemorrhages, that's the other. A subdural hemorrhage most often is associated with an injury to the parenchyma as well. And there is no issues like in extradural hemorrhage that you need to consider while giving your hyperosmolar therapies. You need to give measures to reduce the intracranial pressure, even waiting for a surgery. So as I said, these are the meningeal reflections which form tentorium cerebri and the falx cerebri. Sorry for getting the slide little later in the sequence. So here you are able to now here all these bleeds which we have seen, these all are arising out of the brain parenchyma in the CSF space. Some of them above the dura, some of them in CSF spaces, something beneath the dura, between the brain and the dura. But here we are able to see hyperdense opacification within the parenchyma. These are called as intracerebral hemorrhages. So intracerebral hemorrhages based again on their location, we need to identify, we will be able to look at the etiology, what has led to this bleeding. Common locations where we see bleeding, the intracranial hemorrhages are basal ganglia, brainstem, thalamus. All these structures are the most common locations for a hypertensive bleeds. But if you are seeing a bleed which is not in these places, like in the not in basal ganglia, not in thalamus, not in the brainstem, not in the parenchyma, in the sense bleeds which are located very peripherally, which are very superficial, then we need to consider that there is some other etiology apart from like, hypertension is the common cause for ICH. So if you find bleeds in an unusual location, we need to think of other etiologies like AV malformation, if there are any vascular abnormalities that is causing the bleed. Here there is something called an space of pain lesion. Here you are seeing again opacity, but has very clear margins. So it could be a mass lesion. So the first scan is a contrast scan. How am I saying that it is a contrast scan? Because I'm able to see the blood vessels. So these are all blood vessels. So when I'm able to see a blood vessels on a scan, I think it is a contrast scan. And contrast scan. So whenever you look at something, some space of pain lesion, it is always ideal you do a contrast scan to see how is the contrast enhancement of these things. This structure especially could be a meningioma because it is close to the skull. It is arising out of the it is lying close to the meninges. The second image, what you're seeing here is another space of pain lesion. But how is it to see? You have a hypodense lesion, which on contrast is having a clear ring enhancement. This can be an abscess or this can be a tumor like a glioma. So Based on these findings, we need to decide on our care. If you are thinking on an abscess, then antibiotic, duration, dose, everything changes. If it's a glioma, then if there is signs of raised ICP and you find a glioma, then your anti-edema of choice changes. It rather than going on to hyperosmolar therapies, you might consider steroids. So identifying these things on a CT will help you in giving the right choice of drugs. So just roughly, I'll walk you through some of the images, just to again touch upon the previous image what I have discussed. So the first image which is showing a hyperlucency compared to the left, and you have a right lung which is collapsed, or the lung margins are seen very close under this hyperlucency. So this is a pneumothorax. The second image is showing you a chest tube placed into this thorax to let the air out. And you can see some bronchovascular markings coming up little better, but you can still see the lung margin still here. There is still some hyperlucency continuing to be there in the upper border. So this is a pneumothorax, and this is an X-ray wherein a chest drain has been placed. Here you can see a patient who is very red, inflamed, and with a swollen skin and chest wall. And an X-ray done is not showing anything much within the thorax. But you can see the soft tissue, which ideally should have been black, is filled up with black spaces, which ideally should have been white or dense, opaque, is filled up with white, black spaces. That means it indicates that there is air into the soft tissue, what we call as surgical emphysema. Whenever you see something like this, always search, look at the bones, see if there are any fractures, if there is any trauma-related injury causing the air leak into the skin from the lungs. These people are very highly prone to develop pneumothorax. So whenever you identify any patient with surgical emphysema, evaluate further or keep monitoring to look if these patients have a chance to progress towards a pneumothorax. I think everyone would be easy to identify this. What we are seeing opacification, which is present on both the sides, which is more towards the center or around the hilum, and which is sparse towards the periphery, which commonly happens with pulmonary edema. So this is a patient who presents to us with trauma. The first X-ray, what is it showing? The lung on the right seems to be okay, but the left lung, there is opacification. But there is clear border arising in from out of the opacification. There is no loss of silhouette between the lung and this shadow margin. It is clear. So what is the normal endothelial structure which is present here? Parasternally at the above the left heart border, what we will have is an aortic knuckle or an aortic arch. So in a trauma or a post-trauma, if you are seeing a patient whose mediastinum is widened, always look if there is injury to the aorta. The aorta is a high pressure system. Any injury to the aortic wall will lead to aneurysmal dilatation of the aorta, which can cause an aneurysm, aortic aneurysm. So when you see this CT, you should always think of an aortic aneurysm, which could be an emergency to deal with. The second image, as we all said, grossly looks normal. We are able to see both the lung zones, white and black. Trachea seems to be in midline. Clavicles are fine. The diaphragms are fine. Even under the diaphragm, I don't see major abnormality. But don't forget to look at the bones. Other bones are the ribs. Here you can see the arrows pointing. We have rib fractures. So when you have rib fractures, we need to keep monitoring for few things like patient may be at risk of developing a hemothorax or a pneumothorax or a lung contusion. So a trauma patient, look at the mediastinum, look at the bones, look for air apart out of the lungs, look for blood or look for pleural effusion. Here you can see there is opacification on the right side and extreme lucency on the left side. What does this suggest? There is chance that there could be a significant pneumothorax here. Why am I saying that? Because you see the airway is also going pushed to the opposite side. The heart is being pushed to the opposite side. This means this is a tension pneumothorax that needs to be addressed urgently. The second image, we are seeing gross opacification of the left side, but right side lung seems to be good. But what is happening? When you have such a gross opacification, if there is not air, then it has to be fluid. If it is so much of fluid there, it would obviously push your airway to the opposite side. But here what's happened? That's not happened. The airway seems to be in the middle. But there is something in the airway, that is the tube, which is crossing to the opposite side, which is entering the right bronchus. That indicates that the tube position is wrongly placed. It is gone straight into the right bronchus, and it is that left lung is not getting air, leading to a left lung collapse. That is what needs to be addressed here. So if this patient is hypoxic, maybe a simple intervention like pulling out the tube would help in perfusing or oxygenating the whole of the left lung, which will bring back all the numbers towards normal range. So CTs, as we discussed, so here you can see hypodense area in the left brain, and some other bright structure we are seeing, which is like a thread. So we have a hypodensity, usually indicates stroke, and you have a bright thread-like structure or a hyperdense thread-like structure that indicates there is likely a thrombus in this blood vessel. That indicates this is a acute stroke. The second image you can see, we are seeing two hemorrhages. One is within the parenchyma, one is out of parenchyma but in a lens shape. So as I said, a lens shaped bleed is usually a extradural hemorrhage. So this patient has a left extradural hemorrhage, and here on the right side he has a right parenchymal bleed, or if all this is commonly usually associated with trauma, what you expect here is a contusion. Contusion, how you identify contusion? It is a parenchymal bleed, which is hyperdense where the blood is there, and surrounding it, you see a fine area of hypodensity, which indicates usually edema surrounding the lesion. So this is called a contusion. When you look at these images, apart from these bleeds, you need to look for signs of raised intracranial pressure. How do you see? You need to look at the CSF spaces. You need to look at the sulcal spaces. What I mean, I'm not able to see any sulcal space here. You can see the Sylvian fissure also compressed. Then you need to look for the basal cisterns, that is the CSF space lying around the brainstem. That is the CSF spaces. Are they obliterated, or are we able to see the CSF? Then we need to see whether the right structures of the brain or the structures in the brain are still lying within the same side. Suppose, say, if this extradural hemorrhage on the left is increasing, it pushes the brain to the opposite side. So the brain parenchyma or the frontal lobe tries to herniate onto the opposite side under its partition, that is the falx cerebri. Then what we call it as a subfalcine herniation. Or if the anterior bleeds, suppose say like thalamic bleeds or the basal ganglion hypertensive bleeds, if the edema is increasing or the bleeding size is increasing, it will try to push the brain to herniate back under the tentorium. That is called a transtentorial herniation. So all these signs suggest that there is impending rise in or impending intracranial pressure induced crisis that needs to be addressed either medically or through surgically. So apart from identifying the lesion, also look for complications arising out of these lesions like raised ICP or signs of raised intracranial pressure. See, this is a clear example for this. What are we seeing here? We are seeing a huge lesion here, which has both hyperdense and hypodense signals within this lesion. Usually this is a bleed. On the right side, you are unable to see CSF spaces clearly, and the lateral ventricle on the right side is completely quashed and is being pushed outside, pushed to the opposite side. So what's happening? The ventricles which should have been in the midline are crossing over to the opposite side. This is called as midline shift. We often hear. So ventricles which has to be in the midline are crossing to the opposite side. This is a sign of mass effect or any lesion which is exerting mass effect onto the rest of the brain parenchyma. We measure through looking at something called midline shift. Apart from the herniations which I have spoken, it causes mass effect. The second image here is showing a small bleed which is between the brain and the skull. Is it lens shaped or crescent shaped? So we are unable to differentiate, but definitely this is not lens shaped. So what this usually is a subdural hemorrhage. Subdural hemorrhages grow slowly and cause, and mostly, as I said, subdural hematomas also have associated parenchymal injury. So we need to monitor for parenchymal contusions progressing over days in your care. Thank you. If there are any questions or doubts or any suggestions how we can improve these classes, I am open to discussion. Akash?
Sir, that was a wonderful session, sir. So actually, this is what I want to tell to all the clinical pharmacists, especially when they work in an ICU. You hear a lot of terms like these, discussion in the rounds that it's an EDH, it's an SDH, it's a stroke, it's an ICH, and the treatment modalities for everything it differs. So when do you give antiplatelets? And then when you see the follow-up imaging, when do you stop it if there is an hemorrhagic transformation or not? So when you see a trauma, so what are the basic findings in that? Why do patients get taken up for surgeries? So all of these are part of a clinical round, and usually the pharmacists are clueless when they hear about such things. So that is what this session was about. Like, we should also have a habit every day in your clinical rounds or your pre-rounds or whenever you see the patient that what this patient is actually having. So go through the images, see the chest X-rays, see when you tell that the patient is having an ARDS, you see oxygen requirements changing, you see a ET culture being sent. So we should always follow up on these because it gives you an idea that actually these changes are being happen to the patient, and so your treatment modality or our therapy is also changing, like you rightfully said, sir. So all of these things, as from a clinical pharmacist perspective, is also really very important, which many of the pharmacists they don't learn in their curriculum, and also they don't have an very acute interest also, sir. But it's a very important thing, especially when you work in an ICU. So thank you very much, sir, for this wonderful session. So this is the first session, and I thank you all the viewers also for joining in for today's session. So probably next session we'll discuss with sir, and we'll let you all know through the FCPI forum that what's the topic going to be, and your suggestions and your feedbacks will also be taken, and we'll come to know that what can be improved or what can be taken up for the next session. So thanking you all for today. Thank you, sir. Thank you, sir, for a
Thank you.
valuable time.
Thank you.